Hello everyone, my name is Megan Barney, and I'm a third-year medical student at Oregon Health and Sciences University in Portland, Oregon, here today to present on catheter-associated venous thrombosis among veteran patients. There are no conflicts of interest to disclose. So some background, millions of catheters are inserted each year for reliable venous access in a variety of patients to provide support in the management of both acute and chronic diseases. Central venous access can be achieved through multiple modes, namely a central venous catheter or a peripheral inserted central catheter. Known complications of both of these procedures include central venous stenosis and thrombosis. There are risks and benefits to both of these procedures for obtaining venous access, and studies have not shown a clear superiority of one or the other. However, PICC lines can be placed quickly at the bedside and is typically associated with less of these risks. Existing studies suggest that upper extremity deep vein thrombosis account for 4.4% of all objectively confirmed symptomatic acute DVT or pulmonary embolism. And of these upper extremity deep vein thrombosis, up to 45% were said to be catheter-related, and so that is quite significant. With this in mind, the objectives of our study were to assess the rate of catheter-associated thrombosis, identify possible risk factors for associated thrombosis, and to assess the mortality of catheter-associated thrombosis. This was a retrospective database study that included all patients over the age of 18 in the United States VA database who underwent a first-time central venous catheterization from October of 2015 to June of 2023. Our study excluded all patients who had a history of venous thromboembolism in the 6 months prior to having their central line placed. And then for the purpose of the study, we defined catheter-associated thrombosis as any upper extremity DVT or SVT occurring within 90 days of the catheter placement. And finally, for our analysis, we performed survival analysis and multivariable Cox proportional hazard models in order to understand the time frame of catheter-associated thrombosis and look at the relationship between catheter-associated thrombosis and mortality. Table 1 on the left-hand side of this slide demonstrates the cohort's demographics and clinical characteristics. It shows that there were 11,056 patients included in our study, and the average age of our cohort was 69 years old with an average BMI of around 30. The majority of our study population were male, and regarding the variety of races represented, there were around 70% who were white or Caucasian, 20% who were Black or African American, and the remaining 10% was made up by other racial groups. Of these patients, 338 developed a catheter-associated thrombosis, making up an incidence of 3%. The patients with catheter-associated thrombosis were overall very similar in baseline characteristics and demographics to those without the catheter-associated thrombosis. However, there were statistically significant differences between groups in regard to whether or not they were Caucasian versus Black or African American race, patients with a history of renal disease, and patients with a history of cancer. Then, on the right-hand side of this slide, Figure A shows that the majority of the events of catheter-associated thrombosis occurred within 10 to 30 days of the catheter placement. And then Figure B shows that the mortality in both of these groups were fairly equivalent in the first 30 days. However, by day 60, they started to diverge. Now this slide shows our multivariable analysis. The forest plot in Figure A on the top of this slide looks at the likelihood of catheter-associated thrombosis and demonstrates a 42% increase in risk in Black or African American patients, a 54% increase in risk for those with a history of cancer, and a 66% increase in risk for those with a history of renal disease. And then the forest plot in Figure B on the bottom of the slide looks at the likelihood of death after placement of a central venous catheter and suggests that there is a 46% increase in death among those who develop a catheter-associated thrombosis. This number is staggering, but it's important to comment on the other variables that increase the likelihood of death by 35% or greater, which included a patient's history of cancer, history of renal disease, and anticoagulation 6 months prior to catheter placement. And so our conclusions address the initial 3 objectives of the study. So first, the incidence of catheter-associated thrombosis among veterans in this study was around 3%, the majority of these events occurring within the 10 to 30 days after catheter placement. The variables we were found to increase the risk for catheter catheter-associated thrombosis were whether or not the patient was Black or African American, had a history of renal disease, and had a history of cancer. These findings of renal disease and cancer increasing a patient's risk for catheter-associated thrombosis are in line with the existing literature that accepts these chronic conditions to be associated with a hypercoagulable state. And finally, we found that catheter-associated thrombosis increases mortality in patients after placement of a central venous catheter, and additional research is necessary to address the risks and benefits of prophylactically anticoagulation in patients at an increased risk for catheter-associated thrombosis prior to the placement of a central or PICC line. Thank you for your time, and I will now address any questions that you might have.
I may be naive, but is there only one catheter ever used by clinicians? I mean, in terms of a product?
Like the type of catheter?
Different plastics and different coatings and things like that.
I actually don't know. As a medical student, I haven't yet placed my own catheter lines, so I'm not totally sure. I'm sorry. I imagine there are different types used, different companies that produce the products.
Might there be some variation there?
There may, but this is a national database study looking at all across the United States, so it's not just at one institution.
And I guess the VA hospital may have a central contract for catheters.
Maybe.
Thank you.
Thank you.
All right. Anything else? Great. Megan, thanks.